You're at the cutting edge of cardiovascular sciences. I'm Professor and Chair of the Cardiovascular Sciences Department, John Cooke here, your host. And with me in the studio is my faculty member, Lee Lai. Dr. Lee Lai will be introducing our guest today for the cutting edge.
Good morning and welcome to our show. Today it's my pleasure to introduce our seminar speaker, Dr. Joe Rurik, a postdoc fellow in Dr. Marcus Berger's laboratory at the Karolinska Institute in Sweden. Dr. Rurik received his undergraduate degree in molecular biology and history from George Fox University and completed his PhD in University of Pennsylvania under the mentorship of Dr. Jonathan Epstein, who is a prestigious cellular biologist and cardiologist. Sorry. With Dr. Epstein's group, he has made groundbreaking contributions by developing immunotherapy against heart fibrosis, which published in Nature 2019. Then they further proposed a novel strategy to generate in vivo immunomedicine therapies for the treatment of fibrosis and investigated the complex interplay between the cardiac mesenchymal and immune system, which is published in Science 2022. After that, this in vivo mRNA-based CAR T reprogramming concept has been adopted across a range of diseases, including liver disease, autoimmune disease, cancer, etc. And I believe Dr. Rurik will give some update on his work regarding all this aspect. So without further ado, please join me in welcome Dr. Rurik.
Dr. Rurik, thank you for joining us on the show.
Yeah, thank you so much for having me. It's an absolute pleasure to be here.
We're very excited to hear about the work that you've done with CAR T cells engineered by mRNA to treat cardiac fibrosis. But we thought we'd just talk a little bit about where you are now. Karolinska Institute, a spectacular place for research, a great tradition. Tell us what it's like to be at the Karolinska working there.
Yeah, absolutely. The Karolinska has been a wonderful place to work for me. There are many strengths. We're here in beautiful Stockholm, Sweden, where spring is about to come into full force. And working at Karolinska has many advantages that I've been able to use. Certainly we have technology development as showcased by some of the single-cell RNA sequencing experiments and spatial transcriptomics that have been partially developed here. But we also have a long tradition of clinical-based biological research, especially in the immunology fields. There are many fundamental immunology concepts that were pioneered here at KI. And one of the unique advantages that we use quite often in Marcus's lab is the extensive patient registries. We can follow and identify unique patients across any disease, across most biological settings that can be interesting. And in my experience, a lot of the patients are really fascinated and interested and want to be involved in research in any way that they can, and will volunteer for quite routine biopsies and blood samplings so that we can make really profound contributions. I sit right now in the Center for Infectious Medicine, although we do a lot more than just infectious disease, trying to translate therapies as I did in my PhD and continue to do so. But it's a very exciting place to do research.
Wonderful. When you were there in Stockholm, the Nobel Prize was awarded for mRNA therapeutics to Drew Weissman and Katalin Kariko. Drew Weissman was a collaborator, colleague, co-mentor of yours back at Penn. Tell us what that was like to have your co-mentor, colleague join you in Stockholm for the Nobel Prize.
Yeah, I mean, I still get goosebumps as you described. I mean, it was really special and the timing worked perfectly. The Nobel Prize is many things, but it is cherished by many here in Sweden, and it's held in very high honor and high esteem. It's taken very seriously by the Karolinska Assembly for the medicine physiology, and to be here while Drew was here and Katie to receive their well-deserved prize was just really surreal. and just yeah, very happy for them, and especially Dr. Carrico who's worked very hard in relative obscurity for a very long time, and to finally get recognition that she and Drew deserves.
The Nobel Prize for mRNA therapeutics that they received was for their finding of the modified nucleosides, the importance of modified nucleosides in reducing the toxicity, really, of mRNA, understanding how the modified nucleosides enhance the translational efficiency of the RNA. That came at a really important time for the world, didn't it? The ability to make mRNA that was effective and well tolerated.
Exactly. Yes, and it's built on the shoulders, along with the lipid nanoparticle delivery vehicles, built on the shoulders of decades of work that has really came to fruition a year before the world needed it, in terms of the COVID vaccines that have saved so many lives. And the overall safety profile, it's hard to get a wider test of a new medicine than what the RNA vaccine for COVID has gone through over the last 5 years, both in development and in the rollout around the world. I think we still need to improve accessibility across all patients, but the technology sure is powerful in order to protect. And in my case, what I'll talk about in the next little while is how we can try to advance those into new diseases, and kind of leverage the safety and the cost profile to really bring advanced therapies within reach of patients around the world in all economies.
Yeah. I was reading the other day that 5 billion vaccinations have been delivered around the world. And like you said, there is unparalleled safety and efficacy. There's not a drug that we have that has greater efficacy and safety. It's an amazing track record. And you also mentioned lipid nanoparticles and how long it took lipid nanoparticles to get to where they are now. And Peter Cullis is a friend of mine. He's been working on lipid nanoparticles for 50 years.
Exactly.
And RNA has been around since the 1960s. I mean, there's a tremendous amount of scientific work that's been done to get us to this point. And I'm not sure that's appreciated by the average person because mRNA was so new as a concept for a vaccine. But it's been around, and lipid nanoparticles have been around. A lot of work has been done over the last 50 years.
Absolutely. Yes, and a lot of those technologies and the technicians that have brought them to the forefront where we are now, I hope they will not fade to obscurity because they're made each essential contributions. And it seems like the world of RNA and of LNPs is expanding rapidly. I'll only allude to it a little bit during my talk, but the limits seem either boundless or very far away. I mean, there are minor tweaks to the chemistry of the lipid nanoparticles that completely change the immunogenicity, which you want for a vaccine, but you might not want for somebody in heart failure. But these very meaningful, and to me as a non-chemist, subtle tweaks to the chemistry really change which cell types take up and express the mRNA payload. I use mRNA, but you can just as easily silence genes. You can deliver base editors to modify certain enzymes in the liver and permanently reduce cholesterol levels. These are things that seem like sci-fi and just a few years ago, but I think are very a safe reality in our therapeutic toolbox in the near future.
Well, you and your colleagues are taking mRNA therapeutics to another level with cell therapy, mRNA-generated cell therapies. We're going to hear about that in a minute. But I do want our audience members to know that they can call in with questions, and Dr. Rurik is kind enough to say, we can interrupt you in the middle of your talk with a question. So to ask those questions, if you're on your cell phone, text DeBakey to 37607. So that number is 37607. Text DeBakey, DEBAKEY, and then your message, and we'll get that here in the studio. Or if you're at your computer, go to polev.com enter DeBakey, and then you can ask your question. That's pollev, POLLEV.com. All right, well, with no further ado, let's hear about this exciting new area of mRNA-generated cell therapies.
Wonderful. Let us do that. Well, again, thank you for having me. This is just an absolute pleasure. And I'm happy to answer questions throughout and at the end. So I've been working with these targeted lipid nanoparticles for a number of years, and I'll get to a little bit of the molecular biology in a minute, but I'm going to start in the land of fibroblasts. This is what really drew me to John's lab in the first place. And there are many different fibroblasts scattered throughout the heart and probably throughout your favorite organ. Before I start, I have no financial disclosures, although I will talk a little bit about Capstan Data. This is a company that's in San Diego that is trying to commercialize and bring these RNA-based cell therapies to market. But I have nothing financially vested. So fibroblasts in the heart come in many different flavors. In the healthy adult, they're mainly a homeostatic, healthy fibroblast. They produce extracellular matrix, but they also take it up and remodel it. So it's this constant turnover. But on the setting of an injury, stress, an acute myocardial infarction, chronic heart disease, high blood pressure, there are a lot of different signaling pathways that transition these homeostatic fibroblasts into an activated fibroblast phenotype. And this comes in several different flavors, although I'm kind of distilling it into a simplified model where these activated fibroblasts are the ones that are secreting excess matrix. And that excess matrix is what stiffens the heart, causing a loss of function and a number of other different downstream maladaptive effects. And a lot of work has been done to identify the molecular pathways and drivers of this transition. And a lot of effort has been spent trying to block that transition, but all those drugs have been fairly underwhelming in the clinical setting of heart failure. So Haig, Agajanian, and John, and we thought, well, what if we could only eliminate with a chimeric antigen receptor T cell, only those activated fibroblasts, and we leave the homeostatic fibroblasts to be completely, remain untargeted, and they continue to do their job as they should. It's only those pathogenic fibroblasts that get eliminated. So we went looking for a target antigen that's upregulated on activated fibroblasts and absent from the rest of the body on the homeostatic fibroblasts. And we came up with a list with bulk RNA sequencing data from hypertrophic and dilated cardiomyopathy across numerous different patients. And FAP, or fibroblast activation protein, came out at the top of the list. So we designed with Steve Albelda and Ellen Pure, both at Penn, a chimeric antigen receptor that targets the FAP molecule specifically. And what a CAR is, it's schematized here in the middle. This is the binding domain of an antibody, so we get the specificity of an IgG over here. But what we have done is we have then kind of mimicked the endogenous T cell receptor with the interior, intracellular, and the co-stimulatory domains, so that when the antibody fragment binds its target, in our case FAP on the activated fibroblast, then the T cell, which is equipped with this CAR, is then licensed to kill that fibroblast. And this has had wild success in the treatment of malignant tumors, and it has been extended to many other solid tumors and is in development for a number of different diseases, even outside of cancer. So the target antigen is FAP, but we have to actually demonstrate that in the context of the human heart. And Pedro Mendez-Fernandez, who's now an MD PhD student at Penn, did stainings across a number of different human myocardial tissues, and we see this beautiful reticular pattern in green here that is absent not only in the left ventricle, which we're seeing here, but throughout the body as best as we can tell. And one of the ways that we can tell it's absent is through the use of a positron emission tomography probe, here shown just a few days after an MI, again in a human. So we can directly visualize our target. And you can see in this middle panel, FAPI being expressed and taken up by this PET tracer, where we see the lack of perfusion and the contrast enhancement on cardiac MRI. So it is a very specific marker. So here's Haig. He was a postdoc in the lab. He's now at Capstan, but a fantastic mentor to me as I was in my training. And we used a chronic infusion of high blood pressure into mice. So this is angiotensin II and phenylephrine, consistently administered throughout the length of the experiment. And then we administer classically engineered CAR T cells. And you can see just with the injury alone, we have an accumulation of fibrosis, or these pink bands on the picoserous red staining. And after CAR T cells, we see a complete elimination of the histologic fibrosis that was present, and then an improvement in function. But we're kind of at an impasse. We thought this was quite amazing that we were able to push back the clock on the fibrosis. However, from our friends in the oncology realm, we know that the CAR Ts can persist for decades. And that's fantastic for the kind of constant surveillance against cancer. But we all know that fibroblasts are really critical in the response to an acute injury. They patch up and heal over wounds and prevent rupture of the myocardium. So we wanted a transient approach in the context of a chronic disease where we could have activity against fibroblasts and then it would go away. So we teamed up with Drew Weissman and junior faculty, and his group is Hamid Parhez, to design a transient expression of the FAP CAR T using an mRNA product that we can inject directly into the bloodstream. And that is schematized here. So we have mRNA encoding the CAR. This is wrapped up in a lipid nanoparticle, very analogous to the COVID-19 vaccine. However, T cells don't really like to take up foreign nucleotides. So we have to convince them and trick them into taking it up. And we do that by decorating an antibody on the exterior shell of the lipid nanoparticle, in our case targeting CD5, although numerous other molecules can be chosen. And then once this receptor has been triggered, the entire LNP is dragged in. As the LNP acidifies, its RNA is released, and we get expression of the FAP CAR, turning these T cells transiently into FAP T cells. And over a short amount of time, about 2 to 3 days, the RNA will naturally degrade. Same goes for the CAR, and you will get a T cell back to its state before it was a CAR. So a diagram is great, but it's a little bit harder to pull off in the laboratory. And so for some actual proof, I show you some flow cytometry data, first from 24 hours after injection, just one injection of lipid nanoparticles, and looking by flow cytometry. And I have to thank tons of people, but especially Tyler, Amir, and Isfan for the RNA synthesis and LNP preparations. And what we're looking at is all living splenocytes coming out of the mouse, just showing one representative mouse, and CD3, so all T cells on the X, and the FAP CAR expression on the Y. And you can see that it is robustly expressed by about 20% of T cells in the spleen, and it is exclusive to the T cell compartment. If we change antibodies to some other lymphocyte classes, then we'll skew them there, but it is really selective for what we target. And by 7 days, this is completely gone, although the timeline is quite a bit earlier than that. So we let these animals go an additional 2 weeks to let the myocardium recover after self-killing. And we looked by first echocardiography, and we see that the systolic function as measured by ejection fraction and global longitudinal strain both improve essentially to the healthy controls. So in gray we have uninjured animals, in yellow is injured without treatment or with a non-targeted LNP where CAR Ts are not made. It's the same phenotype here. And then just a single injection of the targeted lipid nanoparticles, we have full recovery of systolic function and diastolic function across the mitral valve, and the histology is quite a bit improved as well. So I'm going to share a couple of different stories today. This is just the first to set the stage. We're excited because we think that this is a really a profound way of pushing back the clock, so to say, on fibrosis. We know in these animals that it is present when the CAR Ts do their business, and then it is absent when we take a look. And this is really a paradigm shift for the treatment of chronic heart diseases. It also has really important ramifications for the realm of CAR T manufacturing, because we now have a single product, essentially a vaccine, that can be administered intravenously to all patients. There is no allogenic T-cell manufacturing, which is a huge bottleneck and a big cost. It allows for redosing over time, and importantly for the clinicians, and I've learned this from them, that we do not need any lymphodepletion, and this is a significant risk for the patients. So next, I'll move, I know this is a cardiovascular symposium, but there are other organs in the body, and you might have a favorite amongst them. And a lot of them tend to get fibrotic. So I'm just going to highlight two examples, although we've made a little bit of progress on all of these diseases. First the liver, and then in rheumatoid arthritis. So the first is a wonderful collaboration with Scott Friedman at Icahn School of Medicine in New York and his very talented MD PhD student, Yasha. So over the years, Scott has developed a model of liver cirrhosis that is progressive, and this involves a wild type background, which is quite important for a lot of therapeutic developments, and administration of Western diet, sugar water, and then carbon tetrachloride at a very low dose weekly will drive progressive fibrosis accumulation in the livers, and eventually, although it's challenging in mice, to get them to hepatocellular carcinoma stage. So we have taken the approach that we can pair this with the FAPI PET tracer in that we can identify patients very early in liver fibrosis stages and intervene before the organ is truly damaged. So here we're injecting the same CD5 targeted lipid nanoparticles that I used in the previous study, but here in the context of liver disease. So first I'll show you that FAP is indeed expressed. It's absent in red on the left picture in the healthy animals in the liver and throughout the body, but it progressively is expressed in these activated hepatic stellate cells, which are analogous to the activated fibroblasts in the heart. This can also be found by RNA sequencing of the single cells from the liver, although here I do have to point out that even in the heart we have seen a lot of post-translational regulation of mRNA for FAP specifically. So we see it in the HSC population as we do with the staining, but we also see it in dendritic cells by sequencing, but we never see it by antibody. So the protein obviously is not made there, and we don't see that in any of our stainings or by flow cytometry. When we look for expression of the transgene after targeted lipid nanoparticle administration to these animals, we're looking at living splenic cells. We see good induction in both CD4 and CD8 T cells and a minor uptake in NK T cells, which are known to express CD5, and a little bit of macrophages by phagocytosis. So for me, this was an enormous relief. This was the LMPs here were generated by a different laboratory than the ones I used in my study. The administration and flow cytometry was done in a different university than mine, and the biology is exactly the same. In fact, it might be a tiny bit better expression that Yasha sees than I saw in my animals. But this was a very nice replication of my results in fairly independent reagents and independent hands. So I'm more confident than ever that it is a real phenomenon and not something that only works at Penn or in the laboratory, and hopefully will actually make it to help patients. So next, Yasha looked within the liver specifically, so living lymphocytes and CD8 T cells, and looking for co-expression of the FAP CAR here on the x-axis, but also CD107A on the y-axis. So this molecule is only seen on the surface of recently degranulated T cells. So what this means is the T cell has to engage its target and try to kill that target for CD107 to be on the surface of that T cell. It's an endosomal sorting protein, so it's always internal unless the T cell has encountered its antigen and is recently killed. So we are fairly confident that there is a good population of living CAR-positive, recently killer T cells entirely within the liver, as we would suspect based on the presence of the antigen and with the arming the T cells with the CAR. So next we measured fibrosis by picoserous red staining, and you can see that the compared to the middle two controls of the disease induction, but the targeted lipid nanoparticle containing cherry mRNA, so no CAR T cell, versus the therapeutic treatment, we see a robust, a statistically significant reduction in fibrosis, although to my eye it's not quite as blockbuster as we saw in the hearts. And so we wanted to really convince ourselves that this histology wasn't something that we were kind of wanting to be true. So we sent blinded slides out to FibroNest for digital pathology, where they can scan the slides and use some computational magic to assign quite robustly both a phenotypic fibrosis composite score and a more detailed kind of morphology-based score to the samples. And again, the exact same improvement in fibrosis was seen with this independent and blinded analysis of the animals' livers, reassuring us that we are not only getting active CAR T cells into the liver that's injured, but they are actually having the intended effect. So Yasha has done a lot more to try and tease out exactly what's going on, and we think it's quite a multifaceted recovery process. The first is a small increase in alternatively activated Ly6E low monocytes that might be helping recover. There is sinusoidal endothelial cell recovery that's pretty consistent, although perhaps needs more time to really robustly re-epithelialize the livers. But by single-cell RNA-seq analysis, there's a really profound rewiring of the metabolism of the hepatocytes within the liver only after clearance by the FAP CAR T cell. That's not seen just with the LNPs alone. So this is not just an effect of lipid nanoparticles in circulation, but it is truly about killing. And what we're looking at here, I think, is two interesting things. First, these are just the hepatocytes in transcriptome. And just with an injury, just with MASH, you can see a big shift in their transcriptome between the two states that does not recover, at least in the broad transcriptome at this timeline. But what we do see is this cytochrome P450 hydrolase enzyme, CYP4A14, does decrease its expression after FAP CAR T clearance, and this is an enzyme that's known to promote directly MASH progression. So another piece of evidence in the pile that there is a rewiring of how the hepatocytes use different metabolism pathways. And by GO-term analysis, you can also see a strong reduction in fatty acid metabolism across the entire hepatocyte population. So this is a fantastic story that's hopefully going to come out soon, and Yasha deserves a lot of credit for bringing this into the world.
We have a question. We have a question that came in, Dr. Rurik, from one of the listeners, and they're wondering about the fibrosis that occurs in cystic fibrosis. Of course, that's if I recall, that's a problem with the chloride channel, but there is a fibrosis associated with it, and you can get other organs involved other than the lung. So I was wondering if you could comment on the general mechanisms of fibrotic tissue remodeling and specifically cystic fibrosis.
Yes, absolutely. Cystic fibrosis, as we're promoting RNA therapies, there are a few cystic fibrosis RNA therapies in development that seem quite effective. But the fibrosis, when we look in humans, it tends to be a very consistent phenotype where it's FAP positive, interstitial, exactly what we demonstrated in the heart and the liver. across most organs in the human. We've looked at probably 20 or so diseases. I don't think cystic fibrosis is one of them. I'm just trying to remember. But what we've seen is, idiopathic pulmonary fibrosis is definitely fat positive, but only in humans. And the reason we haven't made good progress yet on that is because the mouse models don't seem to replicate the human disease in terms of activated fibroblasts in the same phenotype that we see in the humans and we see in the heart. So I think there is great potential for disease like cystic fibrosis and muscular dystrophy, which is very fibrotic. But the animal models are a bit lacking, at least in my hands, for those two diseases that will need kind of more human data in other organs, and hopefully can help those patients as well. I think it's a fairly consistent pathway in the human across different organs, but of course there'll be exceptions where we'll need alternative anti-fibrotic strategies, and there are a couple of other markers in terms of making CAR-Ts against those new markers that are in the very early stages still. So hopefully that answered your question. I'm happy to discuss more at the end.
Sure, that's great. Please proceed, Dr. Rurik.
Great. Yeah, so we have the next short story is with wonderful collaborators at the University of Birmingham in the UK, and that is Adam Croft and his postdoc Sam Kemble. And this is in kind of a follow-up study to Adam Croft's own work, showing that activated fibroblasts are the really problematic coordinators of inflammation and of tissue damage in the rheumatic joint, in rheumatoid arthritis. So this was one kind of, it's an important disease and an interesting therapy that I'll tell you about in the next two slides, but personally, it's fascinating because I love the connection between activated fibroblasts and the immune system. It's a potent axis both in the heart and in numerous different organs. And this study I'm about to tell you is really the critical, most direct line of evidence that I've seen so far of a really important connection between the immune system and the fibrosis systems, both in the heart and in other organs. So we're looking just here in pink at immunohistochemistry staining for FAP in an injured mouse joint. Again, the protein is absent in the healthy situation, and it's the same in the human. It's absent in healthy joints, and it's expressed highly both by transcript and protein in the human injured joint. So this experiment, just in one graph, is a little bit complicated, but hopefully I can explain it in a clear way. What we're looking at by flow cytometry here is the CAR-positive T cells only isolated out of the joint of the animal. So we've taken the joint out and we've purified cells, and you look for the presence of CAR T cells. And here in the normal healthy joint, there's no antigen. So they shouldn't have a reason to go into the joint, and we cannot find them very well. However, when we injure the joint and then inject the CAR-Ts into those animals intravenously, they then can be found in huge numbers in the joint that's injured. So it depends on the presence of the antigen, just as we would hope for. The number of FAP-positive fibroblasts also goes down after CAR-T administration. And then by measures of arthritis severity, and in ankle swelling, and this has happened in multiple different cohorts of animals and two different initiations of rheumatoid arthritis, we have in the red dots a quicker recovery in the animals that received the FAP CAR T cell as compared to non-targeted T cells or alternatively targeted T cells that don't target activated fibroblasts in blue, and the naive non-treated but injured animals in gray. And even the anti-TNF antibody here in green, it does not work as well as depleting the activated fibroblasts in these joints, with the red line indicating the injection day of the CAR T cells. Now, what I think is even cooler is if you re-injure these animals, they are protected from developing the symptoms of rheumatoid arthritis. So we have a single injection of CAR T cells after the first induction of arthritis. So this is a serum mismatch transfer. The first one helps the animals recover a little faster, as seen in these left graphs. But then, without giving a second dose, you're just re-injuring the animals. Those naive animals develop worse fibrosis than the first round, but they are protected immunologically with the absence of the activated fibroblasts from the first round of killing from developing the disease again. And I think this is an enormous, promising sign for the treatment of such a debilitating disease as arthritis is. Now, I've described to you killer T cells. We arm them with a CAR and they go out and they eliminate a problematic pathogenic CAR. But there are many different approaches and different types of T cells that we can think about using. For starters, we can think about regulatory T cells. These are known to calm down inflammatory environments. And we have a project with Teddy Williamson in John's lab that I started and is in his capable hands to use both a engineering approach and a targeted lipid nanoparticle approach to make engineered regulatory CAR T cells for the treatment of an acute heart disease, where we're not trying to kill activated fibroblasts, but we're trying to use them as homing targets to bring in regulatory T cells to kind of calm the post-MI inflammatory environment. Furthermore, we can think about antigen-specific T cell depletion. There's quite fascinating evidence that potentially T cells learn to remember a heart attack, and we can then design custom engineered receptors similar to a CAR that can go after not the whole T cell compartment, but only those problematic autoimmune causing T cells. And we can do this potentially in heart disease, but also in many, many other autoimmune diseases. And lastly, the CD19 CAR goes after and eliminates B cells, which has been a huge success in hematologic cancers like ALL. But recently, the group of Georgette and others at Erlangen in Germany have used CAR T cells with tremendous success against autoimmune diseases, the first of which was lupus. And these were treatment refractory patients that were absolutely headed very much downhill on a clinical spectrum. Given single dose of classically engineered CAR T cells, and their symptoms completely dissolve. They have been off of drugs, I believe, for up to 3 years now, living completely healthy lives. And what's very interesting is they have naive B cells return about 4 months or to 6 months after the injection of the CAR T cells, indicating that you can really reset the system. You can eliminate the problematic B cells and allow new B cells to recover. You can potentially then vaccinate against infectious disease again, get proper humoral immunity developing in these patients, but their symptoms are completely gone. And this is not only in lupus, but in other B cell driven autoimmune disorders as well. So the very last 2 slides of data I have are Capstan's data. So they are trying to commercialize and bring an mRNA-based approach to CD19 CAR T cells. And I think it's important to bring up here in this discussion because they have completely changed the lipid nanoparticle and totally stabilized the mRNA. And they get very low immunogenicity from the LNPs. They're very safe, even in and amongst a very safe vaccine. They have almost no adjuvant properties, and they work profoundly well. So one of the reasons why CD19 CAR T therapy was so successful in lupus as opposed to in these refractory patients, as opposed to rituximab, which is a B-cell depleting antibody, is that while rituximab is good at depleting B cells in circulation, it often leaves behind B cells in the tissue. And what I'm showing you here is non-human primate blood in the top row and splenic tissue in the bottom row, staining for B cells either way. In the control, we have, as expected, numerous B cells, and we're titrating in 2 doses and 3 doses targeted lipid nanoparticles, generating anti-CD19 CAR T cells. And you can see that even at low doses, the circulating B cells are completely eliminated, and in the tissues, at still a modest dose, you have complete elimination of the B cell compartment in these non-human primates, really mirroring what they have seen in Erlangen in terms of the B cell responses in lupus. And exactly the same, they see a recovery of the B cell compartment after a period of complete B cell absence, and when they return, they're of a naive phenotype. So we think that this is very, very exciting. And just in summary, I'll have one slide where I return to the schematic, but now I've boxed all these little different components, and I hope to encourage you to let your imagination run wild. Each one of these things can be changed. The RNA, the LNP, they can all be tuned, to completely change the therapy. You can have an siRNA or a microRNA to degrade a specific transcript. You can boost translation with tricks to the mRNA itself. It does not need to be an activated fibroblast we target, nor an effector T cell. They can be, almost a limitless number of different options, and I hope that you'll take away from my talk just how flexible this technology is, and hopefully that it can inspire totally new therapies that I have not even dreamed of before. So of course these projects do not happen alone, and I'm indebted to a lot of fantastic coworkers and really wonderful mentors, specifically John Epstein, who's just promoted as Dean of Perelman, and Marcus Boogert, my postdoc mentor here at KI. In addition, Drew Weissman, Hamid Aparez are essential. Ellen and Steve, collaborators both here and across the world, are very important. And with that, I will wrap up. Thank you for the opportunity, and I would be happy to discuss and answer any questions.
Dr. Rurik, thank you for a spectacular talk, and I love your galvanizing call for RNA-enhanced cell therapies. Wonderful. You really set the bar high. We have some questions from the audience.
Yes, I think we have an audience who is very eager to see how your technology can be translated. So the question was, what diseases shows the most promise for Fab CAR T cell therapy, and how soon can this research reach the clinical use?
Yeah, these are great questions. I think there are numerous considerations in terms of which disease to go after first. Capstan's priority is to demonstrate that their LNP delivery technology is safe and it works with a known CAR. That's the CD19 CAR that's clinically approved for cancer. So that will prove kind of the safety of the system, at least one approach, although there are more approaches than just Capstan's that are probably all viable. And then I think in terms of fibrosis and fibrotic diseases, one of the things that we need to consider is which clinicians will care for these CAR T recipients, because CAR T therapy on its own has some unique considerations that certainly I don't have any experience in. And so one of the diseases that's quite interesting is myelofibrosis. So this is a fibrotic disease of the bone marrow, but it's cared for by clinicians that have a lot of experience in bone marrow transplant and in CAR T cytokine release syndrome management if those become problems with anti-fibrotic therapy. So I think that kind of crossover would make quite a bit of sense and potentially help these patients. Another idea is in the rheumatoid arthritis, you can inject a very, very limited number of cells directly into the joint. That might limit systemic off-target effects as we kind of understand the human pharmacodynamics and kinetics, and any off-target things we don't know about in the human or the animal studies leading up to human trials. I'm partial to the heart. I think it will have great effect, but I think we need a few different demonstrations of safety before we're kind of at the point of treating chronic heart disease. I think it will happen, but I'm not convinced it'll be first.
So the next question from the audience is asking why you're using CD5 to decorate the LNP, and also after the fat CAR T cells killed to activate fibroblast cells, will the cardiomyocyte get regenerated?
Yes, so yeah, two excellent questions. The first, we use CD5 for a couple of different reasons. One is it's expressed across multiple classes of T cells, and in oncology settings we know that both CD4 and CD8s are helpful. Yeah. And then another factor for choosing CD5 is its endogenous role is as an inhibitory receptor of TCR signaling. So by removing CD5 from the surface of the CAR T cell, even for half a day, it actually boosts the cytotoxic function. The CAR signaling strength goes up by maybe 10 or 15%. So we're getting kind of that little bit extra juice in the system. And then lastly, CD5 as itself is really quick to internalize. It's really, you just tickle it and it will internalize. And so it's really good at dragging in the LNP. That being said, we can target other molecules. CD4 and CD8 both work very well. They results in exclusive expression in the subset of cells that you use, that you target. And then you can also, I've heard some future development trying to target two different receptors, at kind of low affinity, so you need both in order to get in. So that might be a way of targeting kind of low, more specialized subsets of T cells, shall we say. Then the second part of the question was about after fibrosis reduction, do the cardiomyocytes regenerate? I don't know, I think is the best answer. We see in the mice not a huge amount of fibrosis, but it does get resolved. In other experiments, there's more fibrosis, but there's not so much cardiomyocyte death. So we see, an improvement of echocardiography, measured functionality of the heart, indicating that they're a bit happier, but we don't have a really profound insight into whether there's regeneration of the cardiomyocytes or not. I think that's a great experiment for human-based studies that we have ongoing with some collaborators here in Germany, Yuli and Mustroff.
Another question is with respect to FAP, and it comes from Dr. Ben Hay, who's leading a group here in RNA-generated cell therapy. His question is regarding the normal activity of FAP. What is its normal function?
Yeah, it's a good question. FAP is a serine protease that's on the cell surface in development, and then not so much expressed in adult tissues, and then it is expressed in any organ that we see injured. Again, mostly more in the humans. Some of the mouse-based injury models are a little bit dependent on the exact mouse, the exact model. But what we see is pretty much an absence in the adult healthy tissue. And we have a couple of lines of evidence for this. One of my favorites is a process called trogocytosis, which I didn't talk about here, but this is where CAR T cells and other T cells will actually grab onto their target cell and rip out molecules from the target cell while they kill, and they'll hold on to that. So we see FAP as the antigen showing up on the surface of CAR T cells in the spleen, only in the setting where you injure something. It can be muscle, it could be the heart, it could be the liver. But you only see that trogocytosis in the spleen if you also have an injury. So I take this to mean there's not much expression in the healthy adult. Mm-hmm. In terms of its endogenous role, I'm not too sure. It's fairly understudied. My leading theory, hypothesis, is that these activated fibroblasts are also highly migratory, and so FAP might be playing a role in kind of chewing a gap in the fibrosis for the fibroblast to move through to get to the site of injury. But I have very little to no data to actually support that, but that's just a theory.
Yeah. And his second question was then understanding what FAP is normally doing, what kind of side effects might you expect in a clinical trial? And when is the clinical trial going to take place?
I wish I could say soon, but I don't know, and I don't really have control over that, unfortunately. I think the classic CAR-T based cytokine release syndromes, this is an interleukin-6 mediated storm that we surprisingly also saw in the very earliest infections in COVID, a similar cytokine storm-like phenotype in some patients. But so that is now quite easily managed. The clinicians that have practice with this type of therapy are very good at mitigating CRS now. In terms of FAP-specific side effects, there's always a chance that there's a little bit of antigen hiding somewhere in the body that we're not aware of, so very careful dose safety studies will be needed, but that's one of the advantages of the RNA approach, is that we can dose very low. We can also pair it with the FAPI PET scanning to show, this patient is eligible, this patient is not eligible, and we can, kind of build the safety profile from the ground up. Mm-hmm.
You talked a little bit about this, about the specificity of CD5. Did you look at, when you targeted the T cells using decorating your lipid nanoparticles with the anti-CD5 antibody, did you look to see what other cell types were also affected, or also binding to that lipid nanoparticle?
Yeah, so the LNPs that I used were largely taken up by the liver, and what we're doing is kind of we're skewing a component into the T cell compartment. There are newer LNPs that are fairly inert in the body, and they don't get taken up by the liver much at all, and they only are taken up when you add the targeting antibody. Like I said, we can use a CD8 antibody or a nanobody. They work very well to get into those compartments as well. There is a small bit of macrophage uptake and expression that we have seen. I don't think there is much participation in the heart, and the reason why is because those macrophages would need to exit the spleen, go through circulation, and end up in the heart. But even if they did, it probably would be, kind of some benefit to the therapy and the therapeutic recovery. As has been seen, there's a couple of solid tumor CAR macrophages that have been designed.
So I really like this. I feel this system you generate is perfect, and it's in theory can be customized, right? So my question was, if you can like customize this pipeline, what is the most what step give you most technical difficulties, and which step is more like standardized?
Yeah, so it's a good question. It's important as we think about the scale up towards clinical trials. We have the advantage that we're not isolating T cells, right? It's always good to keep in the back of your mind the alternative, which is multi-day allogenetic cell isolation, retroviral engineering or lentiviral engineering, purification, release, send back to the patient. Into that context, synthesizing and purifying RNA at this point is easy. It's straightforward. A lot of companies, I think you guys do it quite successfully. And, LNPs are quite standard. There's machines that have standardized the formation of LNPs. For me, the holdup now is the conjugation chemistry. I think it's a bit dirty still. We use two different approaches. One is acetomalamide chemistry, one is click chemistry, and they both have their advantages, they both have disadvantages, but click chemistry, for example, uses a large amount of enzyme, and that to get GMP grade is a bit expensive, and so I think there are some hurdles in that conjugation of the LNP surface with the targeting moiety, be it an antibody, targeting ligand. That's kind of where I think the most optimization can be found at this point.
So have you compared the efficacy of your ex vivo CAR-T with your in vivo CAR-T? Which one do you think works better?
So what I can say is that I don't think I've injected the exact same experimental cohort with both to compare side by side. But what we see in the first publication with Haig is those were ex vivo engineered kind of classic CAR-Ts infused as a cellular product into the same injury model, same wild type backbone, same injury, and they have full recovery, full improvement of histology. That's exactly what I saw in my hands with the LNPs. So yes, it's a different day, it's a different animal set, but quite consistently we see a full recovery of the fibrosis. So I don't know, I don't care if there's any less efficiency in that setting, right? Inevitably for cancer, you want the most powerful and a proliferative, positive, clonally expanding CAR T cell population to clear a huge number of B cells in the setting of hematologic malignancies. But in the setting of a cardiac fibrosis, I mean, there's a few cells, but there's not a ton. So we need, I think that precision can allow for some inefficiencies in the system. We're optimizing for the disease, not to make the most powerful, potent CARs that persist forever and ever. So it's just a different goal. Those are admirable, but our disease context is different.
Yeah. And it goes without saying that the in vivo CAR-T cell therapy is just so much more feasible. Well, it's accessible, it's affordable. If you approach the efficacy of ex vivo CAR-T cell therapy, then in vivo is still going to be better because of the cost savings. We have another question from the audience, and I think this might be our last one. Interesting question about the type of RNA that you're using for your CAR-T cells. And do you think self-amplifying mRNA or circular RNA might be a better modality for expressing your chimeric antigen receptor?
It's a good question. There's a lot of mRNA technologies out there. In our hands, the self-amplifying vectors are they're derivatives of endogenous T cell viruses, and so they are quite cytotoxic to T cells, just as like a process of amplifying. And so we haven't quite found a way around them. I've tried them a few times in my hands. They don't work that well, and they're a little cytotoxic in the setting of a T cell. They're less cytotoxic in other settings. I think there's been a very successful COVID vaccine based on self-amplifying RNA. And then circular RNA, we haven't done much work with ourselves. Again, I go back to the setting of we see full fibrosis recovery, and if we didn't, we could give a second dose. So we can explore them. I haven't really found the need to yet. We have efficacy with what we have, so we're running forward as safely as we can towards the clinic.
Wonderful. Well, we've reached the top of the hour. Dr. Rurik, I want to thank you for joining us. It's really, truly spectacular talk, really galvanizing a call for RNA therapeutics and cell therapy. And we look forward to seeing what you're going to be doing next. So thank you again for joining us at the show, Cutting Edge of Cardiovascular Sciences, and thank you all for attending today.
Thank you.
Thank you for having me.